Welcome back to the Dental Implant Masterclass. Today we're going to discuss quite an interesting case of a 47-year-old male who had a missing 1/6 and 4/6 that he wanted replaced with implants. This gentleman reported that he had had these teeth lost 10 years prior, and the reason was because of caries, and that's quite an important technical point. One always needs to find out what caused the loss of these teeth, because these require different types of interventions. So let's move and have a look at this case. So for the sake of education, we're going to call this patient Pedro. This case has been used with his consent. And this is the front view of the patient's mouth. And this was Peter's smile line. And as soon as he opens his mouth, you could see his upper front teeth. And of course, a little bit of plaque and calculus getting caught between these lower centrals, which we had to have a little discussion about. On examination, Peter's medical history was pretty straightforward. He had no general diseases, no major risk factors. The only medication that he was on was a statin, 10 milligrams daily for hypercholesteremia. We noted that he had a bit of plaque and calculus getting caught, especially below on these lower central incisors, and we decided to take action, and I had him referred to a periodontist to pay attention to this and a few other areas in his mouth prior to doing any kind of interventions. This is the left side view, and we can see that the patient had a crown that wasn't the most beautiful in terms of color, and also that he had had a missing first molar and drift of the second and third molars, with plaque and calculus getting caught in these areas, and also signs of bruxism, which we were also picked up in the external masseter muscles. There was a bit of tenderness in those areas. This was the right side view, and the patient had missing molars on the upper right quadrant and on the lower right quadrant, and obviously the tongue tends to bulge into this area, as we can see. Now, on the initial appointment, when we saw the patient, he had this tooth number 17 that was basically what I often referred to as a coffin dodger, and was just lying in his mouth, completely mobile. And on that first visit, we actually discussed that this needed to be removed, because this was just a plaque and calculus and a soft tissue infection problem, and this had to go yesterday. And he agreed to that, and on that first visit, we took that tooth out. This was the lower occlusal view with the missing teeth 4/6, 4/7, 4/8, and the upper occlusal view. And we immediately saw that there was a missing DO on the 1/4, and we made some provision to send Peter back to his dentist to have this composite filling restored. And also we can see that the occlusal surface of these molars on the left-hand side of the patient had lost their composites, and this was due to bruxism. We had a long and significant chat about this, but at the end of the day, Peter's instructions were very simple. He said, look, I'm a 57-year-old man, and all I want is my upper and lower missing back tooth replaced. One on the top, one on the bottom, and that's it. And of course, that kind of thing you've always got to take into consideration when treating, in other words, what the patient's desires are. This is a picture of Peter's charting with the treatment planning to replace the 1/6 with an implant and a crown, and on the 4/6 an implant supported crown, removal of the 1/7, which we did on the first visit, and the patient had the missing 2/7 and 3/6 in his mouth, but these areas had closed up because of the drift of the teeth in that area. So after a little bit more discussion, we decided that we were going to proceed with this, and of course the very next logical step is study models and cone beam x-rays. Let's have a look at the cone beam x-rays. So the cone beam x-ray of the mandible presented with really good bone quality and moderate atrophy, and a visible mandibular canal on the 4/6, 4/7 site. The upper CBCT, this was taken prior to removing the 1/7, showed that the patient had good bone quality, but moderate to severe atrophy in the 1/6, 1/7 site. However, It was a very little interesting observation, which I immediately picked up, and as an implantologist, I start going yum yum when I see this kind of stuff. Just to get some orientation, if we look over here, this would be slice number 30, which is over here, as we come out of this molar. And then we wanted to put the implant roughly in this area, where we can see already that there isn't enough vertical bone. However, a little bit distal in this area, what the patient had was a beautiful buccal exostosis. Lovely, beautiful, autogenous bone. And obviously the 1/7, which we removed, had a clear endoperial lesion, which was extracted. So we immediately had a conversation about the fact that although he had good bone width and good bone quality in the 1/6 site, he definitely didn't have enough bone height in that area to support an implant. And we started speaking and having a conversation about a sinus lift, and we spoke about the pros and cons of that. And the first thing that I needed him to do was to go to his GP, because I noticed some pneumatization in the sinuses, and I wanted that managed prior to us doing any kind of sinus intervention. Let's have a look at that a little bit deeper. So we started having a look at the treatment plan, and the implant that we wanted to place in the 4/6 site, this was pretty straightforward. The patient had enough bone width and bone height in this area, and there weren't any complications. This is a plaster model of the upper jaw, and in this area we needed very careful and precise placement of the implant, and so we immediately took the decision that we needed to have some sort of surgical guide, at least for the pilot hole, and I will show you what that looks like. So we decided to use a butterfly-shaped surgical guide, which basically covered and fitted precisely onto the opposing 2/4, 2/5, and 2/6, and in on the 1/4 and 1/5, and then we drilled a little pilot hole precisely where we desired the pilot hole of the implant to be placed. We selected slice -38 on the cone beam for the ideal placement of the implant, and at this point we measured 8.61 millimeters of bone width. However, we only had 4.38 millimeters of vertical height, and me personally, I do not like placing any implant that is less than 7 millimeters. In fact, a 7 millimeter length implant in my hands gives really good long-term stability and predictable outcomes. So we needed to augment the verticals and do a vertical sinus lift in that area to be able to create enough vertical bone. And the rule of thumb for me is that we need to have at least 3 millimeters of vertical bone in order to stabilize an implant. And so because we had 4.38 millimeters of bone in this area, I was happy to proceed with immediate placement of implant and sinus lift at the same time. A little further back at slice -50, the patient had a large and significant buccal exostosis, which was 7 millimeters wide and 7.28 millimeters high. And we discussed with the patient that I would use a piezoelectrical and to harvest this bone and to transplant this bone into his sinus lift. And the patient was prepared and happy, and he consented to having this procedure done. And so, taking the implant width and the available bone, we decided to make provision for an implant, an Ostem US4 SA, which was 5 millimeters in diameter and 7 millimeters long in this 1/6 site. And we would then wait 5 months after placing this implant with a sinus lift, and then proceed with second stage procedures on this patient, and then finally restore this area with an implant supported crown, porcelain fused to metal. We had a further discussion with the patient as to whether he desired us to give him a little partial denture. He wasn't interested. He was absolutely adamant that he wanted an implant in this area. And we also discussed the possibility, or he discussed the possibility, of putting 2 implants on the lower and 2 implants in the upper. And we had an honest conversation, and I explained to Peter that all that was required in terms of long-term stability in his particular mouth. As long as he had a 6-to-6 occlusion, in other words, from molar, from this side to that side, that was more than adequate. And the dental research shows and proves that that is the correct technical evaluation. And so in summary, the treatment plan in this particular case was first referral of the patient to a periodontist to manage his periodontal condition, because if we're doing this kind of work, we wanted absolutely pristine tissues to work with. The second was to refer him to his GP to manage the sinusitis that I'd picked up in his sinuses. The third was sinus lift of the 1/6 site and an implant placement in that site at the same time, and then an implant placed into the 4/6 site, and we would harvest that exostosis in the 1/6, 1/7, sorry, a little bit less, probably that 1/7 area, and transplant that bone into the sinus. Let's move to stage 2, which is the fun part, the surgery.